Welcome to another episode of Brain Buzz, where we delve into the fascinating world of neurosciences and brain health. I'm your host, Dr. Kimon Bekelis.
And I'm your co-host, Jason Wallen. And we have a very exciting episode today with a very special guest.
All right. Yes, we do. With us today is Dr. Dan Calnan, one of our incoming neurointerventionalists, neurosurgeons, neurocritical care docs, and a bunch of other exciting things, right?
Yeah. Thank you guys very much for having me.
Dan, welcome. Dan is part of, our expansion into Nassau County. We've been, I think we've had Sandeep here before, Dr. Mangala, who spoke to you guys a little bit about, but his interests in neurosciences and neurointervention. And now Dan is his partner out there. As we're trying to bring the knowledge and the expertise of the Stroke and Brain Aneurysm Center of Long Island to the folks of Nassau County, and we're very excited to have him. And on a personal note, I know Dan for a while now. Probably when did we meet Dan? Maybe.
So I was a sub-I. Come on, you very much have been.
That brings us back to 10 years. I think I know Dan, or more.
At least
10 years.
Yeah.
So so Dan and I trained together at Dartmouth, and Dan was a medical student when I first met him.
I was a young.
He was young and impressionable, and he's not young anymore, but I think he's still impressionable.
I still wasn't. That's true.
But yeah, so it was it was very exciting to see your career flourish, and of course, when we start neurosurgery, we don't really know what direction we'll take in neurosurgery, and we've had conversations here in the podcast about all the different subspecialties and fields that we have, and. Of course, I took the path of vascular neurosurgery and treating stroke and brain aneurysms and all the blood vessel problems in the brain and the spine. And, of course, not everybody did that. And Dan was in training, much younger than me in training, although he's my age when it comes to true age.
I think I'm older than you.
Oh, boy. But he followed in the same path. And that's very exciting to see that kind of folks that are following you in training will hopefully get inspired by what you do and following the same path, which is really good, and not be deterred by their senior residents. And so, tell me a little bit about kind of your journey through neurosurgery, neurointervention. What made you do this, and what brought you to Long Island? I guess
I was different than you. I mean, as long as I can remember, even when I was a med student, and then. In neurosurgery, PGY2 and PGY7, that's 7's the chief. They're kind of your mentor. They're the person that really introduces you to neurosurgery and gets you started on your way when you first start becoming a resident. And that's what you were for me.
Right.
And as far as I can remember, I mean, you were always interested in vascular.
Right.
From the start. And it wasn't always that way for me. So I did a PhD at Stanford in cancer biology, and I was very interested in neuro-oncology.
Okay.
Even functional, I thought was fascinating, and vascular also fascinating, but it didn't grab me at first.
Okay.
What eventually drove me down that road was actually the stuff we do in the angio suite.
Right.
Because that's the one difference between us and the other neurosurgeons is we have this unique part of our practice that we do that's somewhere across between interventional cardiology and interventional radiology. And it's just very different than everything else.
Right.
And you require special training to be able to do that. I think like you, I like a lot of neurosurgery. I think it's fascinating, fun, spine, brain surgeries, everything. But the ultimate decision for me, and I can remember actually talking to you at your wedding and saying, I don't think I want to go into vascular neurosurgery. And then within 6 months, I said...
And look at him now.
I know. And then within 6 months, I said, I can't give up this angiography part, this part that's such an exciting growing field. I can't do without that.
Right.
And without that, like that's your specialty. And
right.
I mean, for sure, it's been the right decision.
Excellent. Yeah, no, I mean, no doubt, you've done phenomenal. So you made that decision in training. You said, okay, here I am. I need to do vascular neurosurgery. I need to deal with stroke brain aneurysms, wake up in the middle of the night.
That's the downside.
That's the downside. And then you decided to go to do a fellowship, right? And for those of you guys that, of course, are not medical, fellowship is when we go and do a even more in-depth training in the special field that we're interested in under the realm of the same specialty that we're working in. So where did you do that?
So that was at University of Wisconsin, where
Okay.
they have in Madison. It's a very large institution. They have some of the best doctors in the world there, who trained me, and the throughput of there. We trained at Dartmouth.
Right.
Dartmouth is. I also did a fellowship at Dartmouth. It's a smaller area just because it's not centered in Wisconsin.
Large metropolitan area, right.
Exactly. So, the volume at Wisconsin was extremely large, and they had a really great open vascular surgeon, Mustafa Baskaya, and their chairman, Dr. Dempsey, also very well known.
Mm-hmm.
And the people that I trained with, Dr. Neiman and Dr. Agar Kainz and Dr. Ahmed, all very well known in the field, and really got me a lot of experience.
Right.
And introduced me to different ways to do things. So, you've gone around and trained in a lot of places too. And I think that's one of the benefits of working with others is there's always these new ways to do things. And you learn something. Every time I do a case with you or with Dr. Mangla, I learn something new. And it adds to my kit of what I have and what I
Right.
can call on.
Right. That's a great point. We're always learning all the time from everybody around us, of course. I honestly think, you mentioned some phenomenal neurointerventionalists and neurosurgeons, and I honestly do think that the team that we've built at the Stroke and Brain Aneurysm Center of Long Island is second to none. I would get care by any of you guys. Hopefully, I never. But if me or my family ever had a neurointerventional related problem, stroke, brain aneurysms, I would look no further than to have care by you guys, each and every one of you, which is spectacular. Everybody comes from kind of a different background, different training, different education, but it seems to me that we're all working in one direction as one person, rather interchangeable, I have to say.
Yeah, no, honestly, I was very excited to come out here to work with you because you have been a mentor to me. But I wouldn't have transitioned from Penn to here did I not believe everything you just said. Because
Right.
at the heart, what we care about are our patients and our outcomes.
Right.
And if that can't be up to the highest standard, then things need to change.
Right. So then you do your fellowship in Wisconsin, and then you get a job. Where'd you get a job?
So I worked with Penn Medicine. I both worked at times at their main campus in Philadelphia, and then my main place was Lancaster General Health, which was in southern Pennsylvania.
Right. So you started a program out there, and of course, I started bugging you, which is what I do, right?
Slowly.
I think a lot of the people around me will tell you stories about how I uprooted them from wherever they were, and they gave up their lives there, and they came here. And so then I started bugging you to come here to Long Island, and so of course you didn't have any ties to Long Island before,
No.
like most of the people that are part of our team, and now here you are. How do you like it?
I love it. I've been here about a month now. You know my background. I grew up in Western Massachusetts in the Berkshires, where it's pretty
I do, but our viewers don't. So please share.
it's a pretty rural area. My hometown has like 1,500 people in it. So I've never been a huge person that's gravitated to cities.
Mm-hmm.
So even in my training, like Dartmouth, because
Right.
it's not in the
Feels
middle of
close
the
to
city.
home.
Yeah. And for neurosurgeons, cerebrovascular neurosurgery, what we do, we need large population centers. So I never thought I'd be in New York for the long term. But when I came out and visited you and saw your practice and everything, it feels like home. It really does. It feels rural enough that I can get out. I can enjoy walks. I can
Right.
walk through the woods. It's not as if we're in the middle of the city, but at the same time, we have the population that can bring
Right.
us the patients that we can help.
Right, right,
And
right.
that's important.
And what's, of course, what's exciting for you in cerebrovascular or neurointervention? What drives you? What gets you up in the middle of the night, other than a phone call for a
Other than the
stroke,
phone
of
calls,
course?
yeah. I think there's two main things. So first of all, we as neurosurgeons, we always love looking at outcomes, right?
Right.
And neurosurgery, more than anything else I've done, we a lot of times can get that immediate gratification. So when we
Right.
come in the middle of the night for a stroke, a lot of times the next day we can see that this patient who couldn't talk
Right.
and couldn't move their right side is now saying thank you and shaking your hand. And
Right.
for me, there's nothing in the world that makes all of the stuff that we put in
Worth it. Yeah.
worth it.
Yeah.
That interaction is just, it gives you that sense of I've done something with my life. I've helped humanity.
Right.
The other thing that really drives me is I think our field is advancing at light speed. I mean,
Yeah.
we look to interventional cardiology as sort of, they started going down this pathway before us.
Right.
So and that's one of the reasons why where I work at St. Francis, it's a really exciting place because they are the heart center. And it's really exciting to be alongside people who are pushing the limits. But every day we have new things that we can do endovascular, new stents, new coils, new devices. I mean, they're talking about shunts that we're going to be able to work with.
That's right.
Except for pediatric neurosurgery, almost every neurosurgeon hates shunts.
Right.
Because this could be the change that we've been looking for.
Yeah. Yeah, and this is one of the most fascinating things for me. It's the potential of this field, right? Everything in the human body pretty much everything has blood vessels, right? You use blood vessels to get nutrients and pretty much everywhere across the body, and we have unique access to those blood vessels, and we know how to manipulate wires and catheters to get to the most remote parts of the brain without opening the head, right?
There is nothing that is more like a road system
Right.
than the blood vessels, right?
Right.
You have the big blood vessels that are the highways to different states, and then you have little blood vessels that'll go to any little borough you need to get into.
Right.
It's the same thing. It's like it's a tube system
Right.
that we can use, and I think people are really harnessing that more and more, especially in the brain, where you don't want to go through normal brain tissue,
Right.
and you can avoid doing that with this wonderful tube system that we have.
Absolutely. I think a lot of us doing this work are excited about the potential to bring devices, therapeutics, deliver them at. You remember when we were doing something similar? My good friend Fawaz Al Mufti, shout out to Fawaz, in the SVIN conference in Miami, we're talking about it, and he was extremely excited about the potential to bring therapeutics through blood vessels and to bring devices in the most remote parts of the brain.
We definitely, from everybody we speak with, it's definitely something that's going to be on the horizon, and it seems to be sooner than later.
Right.
So that's very exciting.
I mean, there's certainly clinical trials that are now ongoing that are looking into things like that, and of course, like you mentioned, shunts. Instead of for our listeners, instead of taking a piece of tubing, implanting it through the brain tissue into the fluid spaces of the brain, bringing it underneath the skin, tunneling it into somebody's belly, and allowing the fluid to drain constantly. Forget all that big surgery that requires neurosurgeons, general surgeons, possible complications. Instead of that, people are proposing you go through the vein side and connect the veins to the fluid spaces of the brain, because guess what? Normally, that's where that fluid drains in. But of course, if that's inefficient, then you have buildup of fluid. You need to get it out somehow. So why don't you just create another path?
Makes sense, right?
And that's in clinical trials, as you know.
Yeah.
And there's newer types of shunts that are going to be in clinical trials. Also, we will be participating. Our partner, Dr. Marisfoy, is working for us to be able to, he's doing a study currently on a type of shunt, and he's working on bringing it to a clinical trial to humans at the Stroke and Brain Aneurysm Center of Long Island. And so that's one potential, right? And that's one. Then of course, a lot of the excitement comes from expanded indications like treating plaque buildup inside the blood vessels of the brain now with balloon angioplasty, maybe stenting even. Kind of some new evidence have come up after the initial clinical trials.
It's amazing, right? I mean, when we started doing strokes, you look back,
Oh yeah,
what, 10, 15, the initial trials in strokes
about 10 years ago actually.
were terrible. They did not have good outcomes.
No.
And then all of a sudden, now we're 5 times better at treating strokes than our heart cousins are.
Right, right.
That is the difference. In 10 years, we've gone from something not being effective to being one of the most efficacious things we can do.
Absolutely. Yeah, it's one of the most effective procedures we do in medicine, period. And I don't know that anybody can think of stroke today without thrombectomy. And guys, we've had videos on thrombectomy. It's just removing the clot from the brain mechanically, going through the groin or the wrist, navigating up there and sucking it out, or removing it with stents that act like fishnets. So very important to understand that this field is changing every day, every year. Every year is different indications. Of course, the arterial side is exciting. The venous side is exciting. Everything that has to do with the brain and our ability to get to small areas is really amazing. And also our ability to neuromodulate or change behavior of the brain tissue using, again, the blood vessels as a vehicle to deliver devices in areas where you can stimulate the brain. And so you have paralyzed folks that have suffered strokes, trauma, brain injury, that then you're able to stimulate and maybe help them move. Another device that's on clinical trials right now, of course, I know Neuralink is getting a lot of publicity with Elon Musk and everything else, which is perfect. You have that approach from every direction addressing the same problem. But our endovascular colleagues are working on this clinical trial is out of New York City, where people are implanting these devices and are stimulating the motor cortex and are able to hopefully allow folks to regain function.
These stentrodes, I mean, it's building on technology that we have, that we use every day, and then it's adding something to it.
Right.
And it's amazing. There's no part of neurosurgery that we aren't slowly starting to
invade
and become part of as colleagues. Neuroloc, treating stuff. I mean,
absolutely.
Infusions, infusing things to break down blood-brain barriers so that we can deliver therapeutics. Everything that we can be good colleagues,
right?
And say, let's help out with treating this and this.
Right, and on that point, we had my mentor and good friend Pascal Jabour with us, and he spoke a lot about absolutely, and he spoke a lot about his work delivering chemotherapeutics to eyes of children with retinoblastoma, with cancer of the eye, and delivering chemotherapeutics and being able not only to cure the cancer, but being able to save the eye by navigating through the groin in these little babies, navigating teeny tiny catheters and wires, put them into the ophthalmic artery, a tiny blood vessel that brings blood to the eye, and then instilling chemotherapy over several sessions and eventually curing these kids and saving the eye. Normally, treatment for this type of tumor is removal of the eye, what they call enucleation, and then instead he was able to go in and develop this practice. And I don't know, Jason, I mean, you've done a lot of these cases with him.
Yeah.
And I think he has probably the biggest practice in the country.
I mean, we would have people come from all parts of the world, even, China, Saudi Arabia, and it was amazing to see the outcomes.
Right.
Because you had said the original treatment was just to take the eye. Right. And then I think originally it started off just to save the eye itself, maybe not the vision, maybe not cure the cancer permanently. Right. And it evolved into this treatment that was kind of a end all be all.
Right. And by the way, talking about our younger patients, endovascular neurosurgery, neurointervention is one of those fields where, we're not really bound by age. We treat anybody and everybody. We know blood vessels better than anybody in the brain. And we are navigating our catheters, our wires. We can get to where the problem is. and we've all treated young patients. I mean, I have a series of young patients. We're hoping to bring one of our youngest patients here with brain aneurysm to the podcast. I think that would be an interesting thing to do. But yeah, so we're not. To me, that's very exciting that you're not bound by age. You're able to help people no matter what the age is. We don't have there is adult and pediatric neurosurgeons when it comes to open surgery, but when it comes to endovascular, we're it.
No, yeah, absolutely. I mean, looking at the neurosurgeons at, the Hospital University of Pennsylvania and CHOP right next door, there's a lot of interface between those groups,
right?
To be able to go and help things.
And neurointervention is the glue that binds them all together.
It really is. Yeah.
Yeah, that's really phenomenal. And so, part of your job here, part of your mission is to grow the program in St. Francis Hospital and bring it up to a comprehensive stroke center, very similar to Good Samaritan University Hospital, where we were able to achieve comprehensive certification, get to the top of those services, and make the Stroke and Brain Aneurysm Center of Long Island a destination on Long Island and beyond for the care of cerebrovascular disease. And kind of you've been tasked with a similar mission in Nassau County. How do you envision getting this through the finish line? I mean, you've done it before. You've run a program successfully in Pennsylvania. I believe you're charismatic and can get this done. But what's
hopefully this is not the first you're hearing about this either. What?
Listen,
so, what'd you say?
What you've done with Good Sam and the way you've developed things is, I think that's both an inspiration, but also going to be the foundation and how we are going to proceed.
Right.
And Good Sam is an amazing place. We want to get the neural capabilities up to where you guys are.
Right.
And the benefit of St. Francis that you've tasked me with is, like I said, their strong interventional cardiology background.
Right.
They have a really, really good center there with experienced techs, and that gives us a really nice starting point to be able to further expand what we can do.
And of course, you're a researcher at heart. You did a PhD at Stanford before embarking into the world of medicine.
That's why I'm so old.
Yeah, and I know that you have a dedication to clinical trials and expanding that aspect of care, which of course always validates externally a center of excellence. And so I'm sure you're looking into that direction, working on clinical trials and building that aspect of your program.
Yeah, my PhD, as I said, was what we call bench science. So working with cells and DNA and doing things outside the body. So less direct clinical, more basic science research that has applications in clinical. But I don't know if your listeners know, but Dr. Bekelis published something like 100 papers during residency. It's
my sinful past.
It's not even
my sinful past.
It's not even real. Like I don't know of anybody else who did that during a neurosurgery residency. So that's, in all honesty, that's another reason I came here, is because you and I have published many papers together. It's great working with you. And a lot of my passions now for research are centered on pushing our boundaries to be able to treat more diseases, making our treatments better. Certainly looking at devices for our viewers. A lot of the devices that we use in this country go through a very rigid process of approval, and that's appropriate. By the time they get to us, they've already been used in Europe for 5+ years.
Right.
So there's a good background for their safety and how well they will work for certain patients. So that's one of my passions, is really to get our hands on things that might have been difficult to treat before with the tools we had. But now our colleagues in Europe have shown that these are safe. Let's bring them in here. Let's get things moving. Let's use these new coils, these new stents, these new intrasaccular devices, and really develop that in this country.
Right.
And also, expanding the uses for what we have.
Mm-hmm.
A lot of your papers build on databases, and you are amazing at looking at large scale databases, and that's really the only way you can get the numbers you need to be able to see small changes. but those small changes are significant because those are people's lives.
Right.
So 3% difference, those are people's lives. It really is impactful.
Right, and in the setting, of course, you building this program, you're going to be doing research, expanding on clinical trials. You will also, I'm sure, going to have to do a lot of education and teaching and training. How does that drive you? Do you enjoy getting people up to speed and building this consensus of dedicated folks all rowing in the same direction?
I really do enjoy it. I would say much like you initially. If you were to go back to young and impressionable Dan and ask him what he was going to do, he would have said, "I'd be in academics and
Right.
Teaching residents and fellows and stuff."
Right.
I do enjoy that.
Right.
I really do enjoy teaching our APPs that work with us. I enjoy teaching all the techs
Right.
that work with us. And if you're ever in the lab with me when I'm working, I know our techs basically get an education like their
Right.
fellows.
Right.
Because I show them what we're doing. I talk them through what's going on, and I think that's really important. And Jason knows this as a fantastic neurotech, that you guys are you're our right hand men and women who can look at things and help us during the middle of a case and notice things that maybe we're focused on this area, but you can see something happening somewhere else. Up, your catheter slipping back a bit up. And if we educate you to be able to do that, it's like having a colleague sitting there right with us.
For sure. I mean, that's something that I always, whenever I've trained anybody, I said, your goal is eventually to be part of the case. Not just a fixture, not just somebody who's going to hand something to somebody. You want to be able to contribute and really help this patient's journey.
And it is the value of the team, right? So you're doing these cases, you're not there by yourself for a million reasons, most important one being patient safety. You want to create the checks and balances. How many times I hear from, we're a big group of neurointerventionalists, but I hear from all your colleagues, my colleagues, they'd say, "Oh my God, this tech is phenomenal," and the reason is they provide feedback, they point things. You always need multiple eyes in these cases, and to have that team that functions as a well-oiled machine is one of the most precious things that, of course, we need to maintain and cherish. And I think a lot of it will be, and of course, Jason and I, Jason is master educator. He will help you with that, and of course I will too. But that's one of the big things. Tell me, of course, you've treated a lot of patients over the years, and you've learned a lot from them, like we all do every day. Do you have a particular case that's stuck in your head in terms of the things you learned, or how it made you feel, or maybe gave you additional inspiration for the field? Does anything that comes to mind? Any patient, of course, don't mention the patient's name, but
no,
everything else.
So I think there's two types of patients that always stick out in our minds. There's the one that are either a very challenging case or something happened that you need to learn from. And then there's the patients who you have outcomes that, you can't, you're so excited that you were able to help this person. And actually at Penn this year, I was actually able to help a colleague, younger colleague, nurse, who had a basilar occlusion.
Oh, wow.
I don't know. We still haven't really figured out why. She was hypercoagulable.
How old was she?
Dissection, 30s.
Oh, wow.
And she was actually an ICU nurse.
Oof.
And
it's always, of course, we see this all the time, but when it's
that's what hits home, right? That's why it sticks out in my mind, because
right.
it's a colleague, and when you look at it, that this could be the person standing next to you. So, she got into the ED, and for those of us that don't have a lot of clinical knowledge for basilar occlusions, they're deadly.
Right.
If they extend, the basilar artery supplies your brainstem, which is the central processing unit that's required for life. And we were able to get up there, get it out. She went home. I mean, she went home. Basically, she had some numbness in one of her fingers that was resolving. So we go from death's door to a little numbness in my finger that's resolving. She's going to be able to go back to work and go back to her kids those are the cases that, like we said before, that's the reason we do this. That's the reason we get up in the middle of the night,
right?
And we go through all the training that we do, so we can actually make that impact.
Well, with basilar occlusions too, we always, everybody goes, oh, every time you hear it, because, like you said, it's death, or it's you're going to go home and be with your family, or there's that big gray area of that we talked about it before, locked in syndrome.
Oh, yep.
Yeah,
and that's worse.
And what Dan is mentioning, it's actually I do appreciate what you're saying about the case that gave you. See, that's somebody that really cares about patients. This is a very interesting question I ask, because sometimes people will be like, well, I remember this really technically challenging case where I did this and I did that. And that's more about the ego of the surgeon than, look at me, I'm able to treat.
I did good.
Right. Whereas what he's talking about is a rather simple procedure, right?
Yeah.
But it's not about the procedure. It's about the impact that procedure has had on a friend and colleague, and how it changed the life. And I find that question is the most telling about somebody's character. And the reason we do this is not really so that our egos are satisfied by how technically good we are, but more so we're excited about the impact that we have on patients. And what we do in the angio suite is just a vessel to get patients better. It's not a self-satisfying look at what amazing images I can produce by removing clots or by treating brain aneurysms. And I really appreciate that answer. All right, enough with medicine. So what what else do you do in life? Is this like, you wake up in the middle of the night, in the morning, and you do medicine and then do more medicine, and you feed off of medicine? I hope not.
No.
What else do you do? You by yourself in this world? I mean, of course, I know the answer to this question, but just for our viewers.
My wife Heather is a neurooccupational therapist.
All right.
And she more than
I heard all the hearts break.
Yeah. Well, I'll tell you, when I said I was coming on Brain Buzz, she was extremely excited, and hopefully she will be on here at some point to say hello to everybody.
She's a super fan.
She is a super fan. She does an amazing job of keeping me grounded. And what I mean by that is, a lot of times physicians, we focus so much on the brain and recovery. And, for you and I, we'd say, oh, yeah, like this person, we got them back X, Y, and Z, like they're doing really good. And, Heather will remind me that, like,
there's more
person you got to look at.
Yeah, there's more to recovery than lift your arm, wiggle your thumb, and a bunch of other stuff that we do.
That's where she keeps me grounded. I have a 4-year-old daughter who is absolutely amazing, and that's probably been the highlight of my days going home right now, is watching her play outside with my French bulldog, who I also consider to be one of my children, Frankie.
Absolutely. Yeah, great family. I know them well. Your daughter goes to school with my son, so can't escape you, even if I try.
That's one thing. We keep it close here.
It's difficult otherwise. We all need to cover for each other, for work, for family. We hang out in and out of work. So, of course, this is a family business.
And that's important. What you said before, we do need to cover for each other. But having colleagues that you have the utmost respect for, and the ability to say, hey, I know that I can call this guy to come cover for me, and he's going to do a good job.
Right.
Like, I care about these patients, and if I call Dr. Bekelis or if I call Dr. Mengele, like, he's going to do the job that I could do. And I when you believe that in your heart, that's extremely important.
Right.
It lets you sleep at night. Absolutely.
Well, this has been definitely fascinating. I mean, I know Dan well, so, none of this surprises me about what an amazing person you are. But, of course, for our viewers, it's really amazing to have you on. And, of course, this is just an introduction to Dan. We'll bring him back in the future when we discuss interesting subjects. Hopefully we'll bring Heather also, if she graces us with her presence. We're looking forward to you working and helping make this program take off and making us all proud.
I'm excited to be back in closer orbit to you again and to work with your team.
Thank you, Dan. Pleasure to have you. Thank you, buddy. And guys, thank you so much for watching. I hope you enjoyed this episode, and we'll catch you in a new episode, of course, of Brain Buzz Don't forget to like and subscribe, and we'll see you soon.
Thank you.